People who scored highest in dissociation had low amygdala activity, and low activity kind of anywhere we looked. That was interesting. But that was 5 patients, and I would never trust that. Same time I started giving it to my anxious kids, I have them coming through at a higher rate. And so I just had scanned their brains, showing them threatening faces, and said, what's happening for my kids who self-report dissociating? What you can see here, actually, my depressed patients, the ones who dissociated, not only did the amygdala shut off, but the visual cortex shut off. They were shutting off their visual processing to the emotional word. My anxious kids, the more they dissociated, the more their visual cortex shut off. And here they are, their dissociation scores, visual cortex activity, more dissociation, less visual cortex activity. They weren't even processing the stimulus. Could be a statistical artifact. I'm going to bypass that for time because I want to get to one last point before we stop. And the last point is I've talked about activity in some different areas, like the amygdala to positive and negative information. I could talk about the insula, which does body processing. I could talk about my executive control regions. But it's only really interesting if I also talk about connections. This connecting to the amygdala, this connecting to the amygdala, dorsolateral connecting to that. What we're getting to is we have to think of this as a system. And if we're going to think of it as a system, we have to then be able to show it to clinicians as a system. How are clinicians used to seeing these things? Profiles. So you have all of your brain areas lined up here, and you have normal ranges on z-scores here, and you see who's normal on what areas. So the person who has exaggerated early amygdala activity looks like this. Before therapy, it was high. After therapy, it normalized. That same person had exaggerated late amygdala activity. Before therapy, it was high. After, it normalized. Then we can show you, look, the other things that were different were they had very low communication between their dorsolateral and ventromedial areas. So maybe that's what was wrong in driving the rumination, and we can tell stories. Profiles. Our first profile, we have a 40-year-old divorced mother of 3, unemployed, chronic patient. Her depression resolved cognitive therapy, but it revealed an untreated anxiety disorder, so she didn't completely get better. She had hypomania through treatment. It didn't resolve. In cognitive therapy, she did learn to be more goal-oriented. The brain researcher got only this profile and said, look, their sustained reactivity to negative information went down, but they had this reactivity to positive information which stayed high. And their regulation went up a bit, but maybe not a lot. So they said the participant was learning and using compensatory skills. The problem is not processing positive information, maybe related to that hypomania. And the prediction of positive, the participant was somewhat, but not all the way better. So it matched up. The therapist and the researcher's description from the profile matched up. We had that in other cases as well. So a shut-down male patient had increased reactivity to positive information, which was consistent with what the clinician said. Incomplete response. And the clinician wanted us to know, what do we do with the incomplete response? What we showed is that there's a lot of this involvement of this dorsolateral area that's still higher than healthy people. It's this voluntary regulation that's high. They haven't yet automated it. And we said maybe have them keep doing more of the same, and maybe they'll eventually automate it and get better. So maybe we're making some recommendations. Folks, these are just good meaning making. It is not yet science. We're working on making it science. We haven't done statistics. We've got a couple of case examples. I can talk about group level changes on these profiles where we can say, look, the big thing that changes in the group is reactivity to positive information. But that's not yet it. And reactivity to negative information goes down in terms of how many people scored outside the range of controls. And automatic connectivity doesn't actually improve enough yet, so maybe that needs work. That said, there's a lot we haven't done that you would do in typical clinically applicable tests. We've got z-scores, which is good test design, but we haven't evaluated reliability. You can only use a test if it works the same way 2 times when you give it to the same person. We've started to look at that, and it turns out that at least in our areas, I plotting all the brain areas we had good reliability. Subgenual cingulate was reliable, the amygdala, the dorsolateral prefrontal cortex. So I can tell you at least the areas I care about, we had a reliable signal. We have to also talk about convergent validity. So I look, these areas, like the amygdala and the hippocampus, are correlated with self-punishment. We have to generalize across scanners, which we've done. So we're getting there. But a big part of clinical trials is then talking about remission. How many people get better and stay better? I don't want to know the group in general, but how many people are we working for? So I can say things like, for every participant, and this was something that Dr. Greenfield did a lot of. He showed the data from every participant and what happened. So let's try it. 10 of my participants didn't have critical levels of abnormalities to begin with, so I can't really talk about what happened to them. Of the ones who had critical abnormalities, how many of those were preserved after treatment? Less than I would expect by chance. And that's my sort of remission criteria. So maybe I